AEH, or Attention Deficit Hyperactivity Disorder, is a neurological disorder primarily characterized by a malfunction in the brain's executive control system. This results in excessive inattention, hyperactivity, impulsivity, and emotional instability, which are disproportionate compared to the individual's age and persist across different contexts, leading to impairment in children. This inability to pay attention could lead to poor academic performance. It often coexists with other neurological and psychological disorders, along with some non-psychological troubles causing further complications, particularly in our contemporary society. It's worth noting that individuals suffering from AEA may experience hyperfocus, where they become unusually attentive when tasked with an activity they find stimulating or enjoyable. The specific causes of ADHD remain unidentified for most cases, with many instances attributed to a combination of genetic and environmental risk factors. Quite often, environmental hazards expose their impact during the early prenatal stage. In some exceptional cases, a single event, such as a traumatic brain injury, exposure to biohazards during pregnancy, massive genetic mutation, or severe early life nutritional deprivation, may trigger ADH. However, ADH emerging after a traumatic brain injury in adult life is biologically distinctive. Genetic factors hold substantial relevance as ADHD is prevalent in families and boasts a heritability rate of 74. Potential environmental risks could include exposure to toxins and infections during pregnancy or brain injury. Around 5/7 of children are diagnosed with AH using ETSM-IV criteria and 1/2 using ICD-10 criteria. There's a marginal variance in the prevalence rates across different countries based upon diagnostic methods. ADH is diagnosed nearly twice as frequently in boys as in girls, and 16 times more in men than women, oftentimes overlooked in girls as their symptoms may not match the diagnostic criteria exactly. Around 30/50 of individuals diagnosed as children continue to demonstrate ADH symptoms in adulthood, with an estimated 2.58 of adults living with ADH that had its onset in childhood. As adults, their hyperactive behavior is typically replaced by internal restlessness, and they gradually learn coping mechanisms to manage their symptoms. Distinguishing ADH from other similar conditions or from normal high-activity behavior can be quite complex. The topic of ADHD, its diagnosis, and the associated treatment approaches has spurred a great amount of discussion and controversy since 1970s. The discourse has involved a wide range of stakeholders, including physicians, educators, policymakers, family members, and media outlets. The arguments primarily revolve around the roots of ADH and the application of stimulant medications and its therapy. In the present day, there is wide acceptance of ADH as a credible clinical diagnosis in both children and adults. Yet questions remain about its diagnostic criteria and treatment methods. Formerly referred to as AD from 1980 to 1987 and known prior to the 1980s as hyperkinetic reaction of childhood, this condition has long been recognized in medical literature, with records extending back to the 18th century. AD is primarily characterized by inattention, restless or disruptive behavior, impulsivity, issues with academic performance, and relationship problems. The challenge in diagnosing AD lies in distinguishing the point at which normal levels of inattention, hyperactivity, and impulsivity cross over into a problematic state that requires intervention. Studies indicate that individuals with HD are more prone to accidents and that the risk and nature of such incidents evolves over time. For instance, a paper published in Neuroscience Biobehavioral Reviews in June 2021 shed light on 82 research findings that highlighted the higher accident proclivity in individuals with AD. According to the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, and its revised edition, DSM-5-TR, certain symptoms must persist for 6 months or longer to a degree that is significantly more than others of the same age to diagnose it. This indicates a minimum of 5 to 6 symptoms of inattention or hyperactivity impulsivity. Additionally, these symptoms must be observed across multiple settings, such as school, work, or home, and negatively impact functionality or quality of life. Crucially, several symptoms must have been evident before the age of 12. In recent developments, subtypes of ADHD have been discarded and reclassified as presentations of the disorder that progress over time. AD affects individuals across all age groups, manifesting in difficulties with social interactions and forming or maintaining friendships. An estimated half of children and adolescents with ADH face peer rejection compared to 10. 15 of those without the condition problems processing verbal and nonverbal communication, and the tendency to drift off in conversations often hinder their social interactions. Additionally, managing anger and delays in speech, language, and motor development are also typical challenges, along with poorer handwriting due to decreased attention span. However, despite these difficulties, a significant number of ADH children demonstrate similar or even enhanced focus on tasks that interest them compared to their peers. ADH symptoms often coexist with such neurodevelopmental conditions as autism spectrum disorder, ASD, which affects social skills and communication abilities. Indeed, about 21 of ADHD cases also include SD. Approximately 20-30 of children with ADHD also suffer from learning disabilities. However, ADHD is not classified as a learning disability despite its frequent association with academic difficulties. AD often goes hand in hand with other disorders associated with disruptive behavior, impulse control, and conduct problems. Conditions like oppositional defiant disorder, OD, and conduct disorder, CD, occur in a significant number of those diagnosed with ADH. Such comorbidities have distinctive symptoms like argumentative behavior, aggression, rule violations, and sudden outbursts of anger. The frequency of such coexisting disorders is higher than in the general population and has been linked to higher risk of developing antisocial personality disorders in adulthood. Brain imaging studies have confirmed that ADHD and CD are separate conditions and have identified differences in brain structures in individuals with these disorders. Restless leg syndrome, a sleep disorder often linked with iron deficiency anemia, is frequently observed in individuals with attention deficit hyperactivity disorder, HD. However, this could also be a component of ADHD and hence demands thorough examination for accurate differentiation. Another sleep disorder, delayed sleep phase disorder, is prevalent among people with ADHD. Individuals with ADH are known to commonly exhibit comorbid psychiatric conditions like substance use disorders, rendering them at a higher risk for substance abuse, primarily involving alcohol or cannabis. The underlying reasons could be attributed to an altered reward pathway in their brains, self-medication, and escalated psychosocial risk factors. This adds an additional layer of complexity to the diagnosis and treatment of ADHD, with dire substance misuse issues usually addressed first due to their probable severe consequences. Other accompanying psychiatric conditions include reactive attachment disorder, which hinders proper social relations, and sluggish cognitive tempo, a suite of symptoms that mirror another attention disorder and may appear in 30-50 of ADHD cases, regardless of the subtype. Those with ADHD cases, regardless of the subtype, those with ADHD are 3 times more likely to develop eating disorders, and inversely, those with eating disorders are twice as likely to have ADHD. AD trauma and adverse childhood experiences frequently occur together, which may be due, in part, to their common symptoms. Shared symptoms can include irritability, emotional instability, poor impulse control, and forgetfulness. Such overlap can lead to misdiagnosis. Furthermore, traumatic childhood events can exacerbate the risk for ADH, causing changes in brain structure and the emergence of ADH-like behaviors. Increased likelihood of trauma stems from the behavioral outcomes of ADH symptoms. Several non-psychiatric conditions such as epilepsy, obesity, asthma, sleep disorders, and celiac disease are also found to be comorbid with ADH. Children with ADH are more prone to migraines, but not tension-type headaches. Headaches might also be brought on by their medication side effects. A 2021 review highlighted the convergence of neurometabolic disorders caused by natural errors of metabolism on common neurochemical mechanisms that disrupt processes central to H pathophysiology and treatment. This signifies the necessity for collaborative healthcare services to avoid overshadowing of clinical symptoms. The relationship between ADH and suicidal tendencies remains ambiguous due to varying conclusions from separate studies and the confusing presence of additional mental health disorders. Evidences for a direct alliance between ADH and suicide, or for ADH escalating the risk of suicide via comorbidities, are lacking. Some research suggests that individuals with ADH often score lower on intelligence tests, Yet this finding remains contested because of the heterogeneity amongst the ADHD population and the challenge of discerning if attributes like distractibility accounts for low scores rather than intellectual capacity. Investigations have indicated that in ADHD, a higher IQ is often overrepresented due to the exclusion of individuals with lower IQs from such studies, even though people with ADHD generally score 9 points lesser in standard intelligence measures. However, counterclaims also exist which suggest an increased chance of missed ADHD diagnosis in intellectually high-functioning individuals due to their compensatory strategies. Research involving adults seems to indicate that the negative variances in intelligence may not be significant and can be ascribed to associated health complications. ADHD is typically attributed to neurological complications in processes related to the creation or utilization of dopamine and norepinephrine in certain brain areas. Yet its root causes remain unknown. It is speculated to involve interplay between genetics and the environment. Several studies and literature reviews published between 1999 and 2019 reported ADHD heritability estimate to be approximately 0.74 to 0.74 to 0.8, suggesting a high degree of genetic influence. In addition, it is argued that the male-to-female sex ratio in ADHD epidemiology implies a continuum with males overrepresented at the extreme end. ADHD has a heritability of 74, implying that 74s of ADHD implications in a population can be traced back to genetic factors. Studies have identified a multitude of gene variants, which subtly increase the chance of ADHD, indicating that it is polygenic and results from the interplay of multiple slight-effect gene variants. ADHD is marked by low dopaminergic functioning and hence arousal, which is directly linked to dopaminergic functioning. Various genes have been identified as contributors to HMAE, many of which directly affect dopamine neurotransmission. Besides, siblings of ADHD-afflicted children are 3-4 times more prone to the disorder than those without the disorder. In certain instances, gene variants like latrophilin-3 have been found to be particularly responsive to stimulant medication, thereby responsible for about 9 of HE cases. Numerous small-scale studies have found that certain genetic polymorphisms linked to catecholaminergic neurotransmission, or the snare complex of the synapse, can help determine an individual's response to stimulant medication. While rare genetic variants have a noteworthy clinical impact due to their high penetrance, their diagnostic application is limited as no single gene can predict ADHD. Noteworthy that both common and rare genetic variations show some overlap between ADHD and AD. Apart from genetics, certain environmental factors may also contribute to the development of ADHD, fetal alcohol spectrum disorders, which may present ADHD-like symptoms, can be caused by maternal alcohol intake during pregnancy. Exposure to toxins such as lead, polychlorinated biphenyls, and certain insecticides has been linked to an increased risk of developing ADHD-like problems. Though the evidence remains inconclusive, tobacco smoke exposure during pregnancy can disrupt central nervous system development and increase the risk of ADHD. Factors like extreme prematurity, very low birth weight, severe neglect or abuse, social deprivation, and certain infections from pregnancy to early childhood can also contribute to the risk. Interestingly, around 30 of children with a traumatic brain injury will later develop ADHD, and roughly 5 ADHD cases are due to brain damage. There's a possibility that a subset of ADHD may be attributed to hypokalemic sensory overstimulation, which can be managed with oral potassium gluconate. Contrary to common misconceptions, excess sugar intake, excessive television viewing, poor parenting, and socioeconomic factors do not cause ADHD, though they may aggravate the symptoms in some individuals. Concerns have also been raised about the potential link between increased use of screen media and ADHD-related behaviors. While studies have found a statistically small yet significant relationship, the jury is still out on this. Lastly, while food dyes, preservatives, and certain food intolerances or allergies may worsen ADHD symptoms in a small number of children, the evidence is weak and requires further investigation. Several studies have demonstrated a compelling relationship between screen time usage and the incidence of attention deficit hyperactivity disorder, AEG, in children. A Canadian study in April 2019 revealed children, 22 participants aged 3 and 5, exposed to more than 2 hours of screen time daily were 77 times more prone to meet ADHD criteria than those limited to less than 30 minutes. Similar findings occurred in an Italian study involving 1897 children from 42 kindergartens in Wuxi, China, suggesting an increase in age likely due to more than 1 hour of daily screen exposure. The study also correlates these findings with potential autism spectrum disorder as development. Another research in November 2020 involving 123-year-old children concluded that higher screen time led to lower scores in expressive, receptive language across comparison groups, associating screen time with behavioral phenotypes rather than familial ASD or ADHD. A 2015 study correlating bedroom TVs with children diagnosed with ADHD discovered those with a bedroom TV had a significantly higher average weekday screen time, leading to a 321 higher probability of exceeding 2 hours screen time daily. A July 2021 study on 374 French children aged around 10.8 years suggested that evening screen time use resulted in more sleep disturbance and ADHD symptoms. Researchers found that specifically evening screen time led to sleep disturbance, subsequently causing heightened ADHD symptoms. Additionally, studies have found that the youngest children in a classroom are more often diagnosed with ADHD, possibly because they are developmentally lagging behind the elder classmates. Younger students in 5th and 8th grade were found to be almost twice as likely to use stimulant medication compared to their older classmates. The narrative's focus is on the neurobiological understanding of ADHD, specifically on how it affects certain brain functions and structures. ADHD is often linked to disturbances in brain neurotransmitters, especially those related to dopamine and norepinephrine. These pathways, originating from the ventral tegmental area and locus coeruleus, influence various cognitive processes and are found in different brain regions. A fundamental aspect of ADHD's pathophysiology is the direct modulation of executive function, motivation, perception of reward, and motor function by these exact dopamine and norepinephrine pathways. Notably, ADHD in children is characterized by a general decrease in certain brain structures' volume, particularly with a larger reduction in the left-sided prefrontal cortex size. A thinning of the posterior parietal cortex is also noticed in aged individuals compared to the controls. Differences in brain structures in prefrontal, striatal, cerebellar, and prefrontal striatal thalamic circuits have been observed between individuals with and without ADHD. There is a discernible difference in researchers' findings regarding the subcortical volumes of the accumbens, amygdala, caudate, hippocampus, and putamen in ADHD individuals compared to the controls, with the former group appearing to have smaller brain structures. My studies have also indicated differences in the white matter, particularly in the asymmetry between the two hemispheres in ADHD and typically developing youths. AD and control brains have been distinguished by differing measures of connectivity between subcortical and cortical regions in Evermar studies. The degree of hyperconnectivity is often associated with the severity of inattentiveness or hyperactivity. Moreover, hemispheric lateralization processes have been proposed to have a role in ADHD, but the empirical results on this subject are conflicting. Previously, it was thought that an increased number of dopamine transporters in people with ADHD was a part of the condition's pathophysiology. Current thinking, however, suggests this increase might be an adaptation to exposure to stimulant medication, the locus coeruleus, noradrenergic system, and the mesocorticholemic dopamine pathway are now considered crucial components of contemporary AD models. It is due to neurotransmitter activity increasing in these systems that ADHD psychostimulants have shown treatment efficacy. Potential abnormalities may also exist in serotonergic, glutamatergic, or cholinergic pathways. The maturation process of the brain in people with ADHD might present distinct longitudinal patterns, suggesting the potential for the enhancement of executive functions in adulthood. Among children with ADHD, there is often an evident deficit in motivation, notably a struggle to prioritize long-term rewards over immediate gratification, leading to impulsive behavior. There's also an intriguingly frequent occurrence of paradoxical reactions, evident in about 10-20 of patients, which are anomalous responses to neuroactive substances such as local anesthesia, sedatives, and painkillers. These paradoxical reactions, possibly genetic in origin, suggest particular caution before surgeries or similar procedures. Diagnosis of ADHD typically includes thorough evaluation of a person's behavioral and mental development, excluding the potential impact of drugs, medication, and other health or mental issues. Diagnostic steps usually incorporate feedback from parents and teachers. Post noticing the teacher's initial concerns, Though exhibiting a spectrum of human traits, HI borders on extreme ends. Brain imaging scans, however, don't yield consistent results and are relegated to research rather than diagnostic purposes. In North America and Australia, the DSM-5 criteria are commonly employed for diagnosis, while European counterparts prefer the ICD-10. The DSM-IV criteria demonstrate a 3-4 times higher likelihood of diagnosing ADHD. ADE might be categorized as either a disruptive behavior disorder along with OD, CD, antisocial personality disorder, or a neurodevelopmental disorder. Diagnosis doesn't necessarily infer neurological dysfunction. Simultaneously, anxiety, depression, OD, CD, learning and language disorders should be screened for, not ignoring other neurodevelopmental disorders, tics, and sleep apnea. Screening and evaluation typically involves self-rating scales like the ADH rating scale and the Vanderbilt ADH diagnostic rating scale. Electroencephalography is generally insufficiently accurate to diagnose ADHD. Diagnosing psychiatric disorders, including ADHD, calls for a qualified professional's expertise, referring to a predetermined set of criteria. In the U.S., the American Psychiatric Association provides these criteria in the DSM. According to the DSM-5 and the DSM-5 tier editions, ADHD can be classified into 3 presenting types, namely, ADH predominantly inattentive type. Symptoms include easy distraction, forgetfulness, daydreaming, disorganization, poor concentration, and task completion difficulty. Predominantly hyperactive. Impulsive type. Symptoms encompass excessive fidgeting and restlessness, hyperactivity, and an inability to wait and stay seated. In the 11th revision of the International Statistical Classification of Diseases and Related Health Problems, orchestrated by the World Health Organization, Attention Deficit Hyperactivity Disorder, ADHD, earned its designation under the Code 6 of 5. The demarcated subtypes correspond closely with those outlined in the DSM-5, including predominantly inattentive, predominantly hyperactive, impulsive, and the combined presentation. However, the ICD-11 initiates 2 additional categories for individuals who don't completely align with the predefined subtypes. This allows more specific diagnosis based on an individual's phenotype or unspecified presentation. Drawing a parallel between the ICD-10 and ICD-11, symptoms of hyperkinetic disorders in the former find correlation to AD as defined in the latter. Coexisting conduct disorders led to the condition being denoted as hyperkinetic conduct disorder. Without it, the diagnosis was a disturbance of activity and attention. Other hyperkinetic disorders or unspecified hyperkinetic disorders, occasionally termed as hyperkinetic syndrome. A critical perspective derived from the social construct theory of 8A implies a subjective demarcation between normal and abnormal behavioral patterns, resulting in a fluctuation in diagnosis. This observation has led to individuals like Thomas Saz to assert that ADHD is a constructed, named phenomenon. The process of diagnosing adults with ADHD parallels with that of children, wherein signs appearing between the age of 6 to 12 establish the groundwork. While the core symptoms of ADHD maintain similarity across different ages, its manifestation varies. For instance, the pronounced physical activity in children may express as a constant mental activity in adults. The current global assessment estimates that about 2.50 adults persistently exhibit ADHD with evidence of childhood onset. Meanwhile, 6.76 adults manifest symptoms of ADHD, irrespective of their childhood onset. This represents an approximate 139.84 million and 366 million individuals, respectively, in 2020. This led to an evolution in diagnostic criteria with age, with some exceeding the parameters of DSM-EE as they aged. Unlike the EDSM-IV, the DSM-5 distinctly includes adults and acknowledges the differences in impairment seen between childhood and adulthood for an adult diagnosis. Symptoms must date back to childhood. However, a portion of adults diagnosed with ADHD wouldn't have met the criteria as children late. Onset at age typically develops between 12-16 years, qualifying for early adult or adolescent. Onset at the DSM provides alternate diagnoses for specific symptoms, with the most suitable diagnosis determined through clinical history assessments. The DSM-5 considers conditions like odd intermittent explosive disorder, other neurodevelopmental disorders, specific learning disorder, intellectual developmental disorder, ASD, reactive attachment disorder, anxiety and depressive disorders, bipolar disorder, disruptive mood dysregulation, disorder, substance use disorder, psychotic disorders, medication, induced symptoms, and neurocognitive disorders. It also considers PTSD. Most, but not all, of these conditions also commonly coexist with ADHD. Symptoms of ADHD such as low mood, mood swings, or irritability are frequently confused with dysthymia, cyclothymia, bipolar disorder, or borderline personality disorder. Symptoms from anxiety disorders, personality disorders, developmental or intellectual disabilities, or substance abuse may overlap with ADHD. Medical conditions like hyperthyroidism, seizure disorder, lead toxicity, hearing deficits, hepatic disease, sleep apnea, drug interactions, untreated celiac disease, or head injury can also cause ADHD-like symptoms. Primary sleep disorders may influence ADHD symptoms, while ADHD symptoms may disturb sleep. As such, regular sleep problem assessments are recommended for children with ADHD. Sleepiness may manifest as classic symptoms like yawning and rubbing the eyes, or as hyperactivity and inattentiveness in children. Obstructive sleep apnea may also result in ADHD-like symptoms. Management strategies for ADHD typically include counseling or medications, either alone or in conjunction. While treatment may improve long-term outcomes, it doesn't completely eliminate negative outcomes. Stimulants, atomoxetine alpha 2 adrenergic receptor agonists, and sometimes antidepressants are commonly used medications. Positive reinforcement could be beneficial for those struggling to focus on long-term rewards. ADHD stimulants improve persistence and task performance in affected children. Observational and registry studies have shown that pharmacological treatment of ADHD is linked to increased academic achievement, decreased school absenteeism, reduced emergency hospital visits following trauma, lowered suicide rates, and a reduction in substance abuse and criminality. The narrative explores the range of treatments available for managing the varied behavioral issues exhibited by those with ADHD, particularly resistant and non-compliant behaviors. Though the value of parent education and family therapy is discussed, the lack of comprehensive research regarding the latter offers room for future studies in the same vein. The prospect of utilizing ADHD focused support groups to provide vital education and coping mechanisms is proposed. The necessity of employing social skills training, behavioral alteration, and medication for improving peer relationships, albeit limited, is expounded upon. High-value friendships devoid of negative influences significantly contribute to averting future psychological issues. In the realm of treating ADHD, stimulants such as methylphenidate and amphetamines often emerge as the primary options, boasting positive responses in approximately 70% of those with ADHD. However, the emergence of side effects such as insomnia present across various stimulants often result in discontinuation of the medication. Other side effects, including tics, reduced appetite and weight, emotional instability, and rare cases of stimulant psychosis and mania, also contribute to premature termination of the treatment. Using amphetamines early on in treatment seems to be related to the appearance of these side effects. The effectiveness of these medications for pregnant individuals remains undetermined. Although uncertainties linger around long-term impacts of ADHD medication, generally, stimulants prove beneficial and safe short-term solutions. However, the lack of long-term benefits once discontinued is crucial to note. A recent study in 2022 found no significant correlation between ADHD medications and cardiovascular disease, but encouraged further analysis, particularly for those with existing heart conditions and on an extended medication regimen. Those receiving long-term treatment are advised to undergo continual monitoring. While it is implied that occasional breaks in medication could be beneficial for reducing tolerance, assessing the ongoing need for medication, and mitigating potential growth delays. Although the addictive potential of stimulants prescribed for ADHD is high, therapeutic doses possess low abuse potential. While treatment with stimulants either protects against substance abuse or presents no effect, nicotine and other nicotinic agonists have demonstrated promising results as an alternative treatment. Ultimately, though, such drugs are yet to receive approval for managing ADHD. 2 FDA-approved non-stimulant drugs, atomoxetine and viloxazine, offer an alternative treatment for attention deficit hyperactivity disorder. 8A, their efficacy and tolerability stand comparable to methamphetamine in tolerability, but fall slightly behind amphetamine. Considering atomoxetine's lower risk of fostering dependence, it can be favored for individuals prone to addictive or compulsive stimulant use. However, more research is essential to support this view. Atomoxetine is shown to remarkably improve academic performance, with studies claiming its efficacy and tolerability turns out to be on par with methylphenidate in young people and adults alike. Clinical trial data analysis imply that viloxazine echoes the effectiveness of both atomoxetine and methylphenidate with fewer side effects. Additionally, amantadine has exhibited similar advancements in children treated with methylphenidate, with lesser side effects. A study in 2021 proposed that it might accompany stimulants effectively for ADHD-related symptoms, marking a safer substitute to second- and third-generation antipsychotics. Bupropion is also off-label, utilized by some clinicians keeping research findings in mind. Even though there's insufficient evidence on its impacts on social behaviors, antipsychotics may help manage aggression in AD as well. We also have two FDA-approved alpha-2A agonists, guanfacine and clonidine, for H treatment. Although their effectiveness is slightly less compared to stimulants and non-stimulants, they offer viable alternatives or can complement a stimulant. Treatment guidelines differ across countries. UK's National Institute for Health and Care Excellence advocates its use for children only in extreme cases, while for adults, medication is a primary treatment. Contrarily, US guidelines suggest medications for most age groups and are not recommended specifically for preschool children. There can be instances of underdosing of stimulants leading to inefficacy or eventual loss of effectiveness. This off-label dosing issue exists primarily among adolescents and adults, as approved dosage guidelines predominantly cater to school-aged children. The interplay between physical activity, stimulant medication, and cognitive performance is a key focus of mental health research. Working out while on such medication appears to enhance its impact on executive function, which is attributed to the increase in dopamine and norepinephrine levels in the brain. As of 2019, authoritative bodies including the American Academy of Pediatrics, the National Institute for Health and Care Excellence, and the Agency for Healthcare Research and Quality do not endorse dietary modifications due to lack of substantial evidence. Data from a 2013 meta-analysis showed that only a fraction of ADHD-affected children experienced a decrease in symptoms through free fatty acid supplementation or reduction in artificially colored food consumption. This improvement, however, might be specific to children with food sensitivities or those undergoing AD drug therapy. A 2017 review also suggested that certain restrictive diets may benefit young children unresponsive to medication. Nevertheless, chronic iron, magnesium, and iodine deficiencies are suspected to exacerbate ADH symptoms. A connection has been found between ADH and lower levels of zinc in the body, though zinc supplementation is not advised unless in cases of proven deficiency. Remarkably, zinc supplementation has been shown to improve the effectiveness of amphetamine treatment. Around 30-50s of ADH cases continue into adulthood. Affected individuals tend to develop coping strategies to manage their symptoms. It is worth noting that such children face a heightened risk of accidental injury. Administering medication has been proven to positively impact these individuals' quality of life by reducing such risks. Besides healthcare implications, ADHD has socio-legal ramifications as well. For instance, the rates of smoking and prison representation are alarmingly higher in individuals with ADHD. Meta-analyses in 2015 and 2018 estimated that 25.5 and 26.2% of prison inmates have ADHD, respectively, within high-security facilities. This rate escalates as Swedish prison reported 40 of its long-term inmates have had. Alterations in ADHD diagnosing procedures and willingness to medicate might be the primary reasons for the elevated perception of the condition's prevalence, rather than an actual rise in occurrence. The 2013 release of the DSM-5 was suspected to raise ADHD diagnosis rates, particularly amongst adults due to modifications to diagnostic criteria. However, significant disparities exist in the diagnosis and comprehension of ADHD across racial lines, leaving many non-Caucasian children undiagnosed and untreated for the condition. Unmistakable differences in understanding ADHD among Caucasian and non-Caucasian populations in the U.S. lead to its misdiagnosis, with its manifestation often misconstrued as mere behavioral concerns instead of a psychiatric condition. There is a general reluctance among non-Caucasian communities to embrace an EH diagnosis due to historical mistreatment and suspicion of medical practices, especially stigmatized medical interventions targeting African American populations during slavery. Misdiagnosis in ADH can potentially stem from racial stereotyping and variation in presentation of symptoms across racial lines, further complicating the already subjectively ascertained symptoms. Documentations on hyperactivity, a component of ADHD, trace back to remarkable observations by Sir Alexander Crichton in 1798, describing mental restlessness in children. In a 1902 series of lectures, George Still's explicit descriptions of H credited him with its first identification. Alfred Treadgold successfully corroborated the link between cerebral damage and behavioral or learning impediments after the 1917, 1928 encephalitis lethargica outbreak. The terminology for the disorder has evolved from animal brain dysfunction in DSM-I 1952 to hyperkinetic reaction of childhood in DSM-I 1968 to attention deficit disorder with or without hyperactivity in DSM-I 1980. The term ADE eventually appeared in DSM-III in 1987 and was retained with subtypes added in DSM-IV 1994, DSM-5 2013, and DSM-5 2022. Benzedrine, the first amphetamine medication to gain approval in the U.S., was introduced in 1934, followed by methylphenidate in the 1950s and enantiomer dextroamphetamine in the 1970s. Since the 1970s, the issue of AH8 attention deficit hyperactivity disorder, its diagnosis, and the methods of treatment have been subjects of controversy, including various stakeholders such as clinicians, educators, policymakers, parents, and media outlets. The controversies rise from differing perspectives. While some consider ADH within the spectrum of normal behavior, others hypothesize it to be a condition grounded in genetics, the administration of stimulating medications to children, the diagnostic procedure, and the potential overdiagnosis are also contentious points. Despite acknowledging these controversies, the National Institute for Health and Care Excellence in 2009 stated that the prevalent treatment methodologies and diagnostic measures are based on the majority academic opinion. In contrast, Keith Connors, an early advocate for recognizing ADHD, opposed the widespread diagnoses in a 2014 New York Times article. Another 2014 research reflects the underdiagnosis of ADHD in adults. However, the variable rates of ADHD diagnosis across countries, states, races, and ethnicities prompt suspicions about other factors influencing these rates, such as cultural norms. The conception of ADH as a medicalization of deviant behavior further contributes to the debate. Despite these discordances, majority of healthcare providers affirm the existence of ADHD, particularly in individuals with severe symptoms. In the realms of healthcare, discussions primarily focus on diagnosis and treatment for individuals with mild symptoms. However, there lacks a consensus regarding the goals of ADH treatment and diagnostic standards. Rarely are children's subjective experiences considered in assessing the efficacy of ADH treatments. Interestingly, studies have highlighted a significant correlation between the timing of births and aged diagnosis, where children born later in a given year have a higher likelihood of being diagnosed and treated, with this pattern being more prominent in boys. This suggests that the diagnosis of ADH can be influenced by subjective analysis. Lastly, the potential positive traits associated with ADH is a new area of research that is still in its preliminary state. The narrative primarily focuses on the struggles of individuals with ADHD, attention deficit hyperactivity disorder. These difficulties often involve the cognitive process of convergent thinking. This thought process involves using essentially relevant knowledge in a concentrated effort to achieve a single optimal solution to an issue. Correspondingly, the erratic time management and habitual procrastination of iconic historical figures like Leonardo da Vinci echoes the typical characteristics of ADHD, continually shifting from one task to another. Significant disparities have been found within biomarkers such as platelet monoamine oxidase, urinary norepinephrine, urinary MHD, and urinary phenethylamine between individuals with ADH and those without. They could potentially act as diagnostic biomarkers, but more thorough research is required to verify their value in the diagnosis of ADH specifically. The levels of urinary and blood plasma phenethylamine are lower in HD individuals compared to the control's AD medication. Amphetamine and pheticate methylphenidate indeed boosts the production of phenethylamine in those who respond positively to these particular treatments noticeably. Lower levels of urinary phenethylamine have been linked with symptoms of inattentiveness amongst those afflicted with AGIT.